Thank you. So, switching gears to the talk, and again, an area where we have not so happy with the immunotherapy. That is, previously I highlighted how immunotherapy era is evolving in lung cancer. Here I come back to an area where we know immunotherapy is not so useful sometimes in our settings. That is recurrent metastatic head and neck cancers. What is the problem? Our patients have a very large burden of the disease. We know these landscapes evolving. I will not go into detail, but yes, extreme regimen came in 2008. In India, it came around 2014. Immunotherapies in second line setting came in 2017. And at TMH Mumbai, when we were doing DM, Dr. Preeti, Dr. Amit, and I were there in the same batch, in the same group also. We utilized immunotherapy in the second line setting with nivolumab in a lung cancer patient and head neck patient in second line setting in 2017. And in 2019, TPX regimen with a combination of immunotherapy came into action. TPX and immunotherapy in combination with cis-5FU, and TPX followed by immunotherapy. All these are multiple other options. So what is the problem with the head neck cancer, which is making it different from lung cancers, where we so much fan of about immunotherapy? Here, the problem is that the patients have huge symptom burden. The patients have a huge amount of local disease burden, making them difficult to take any food. They making difficult to even put Ryle's tube sometimes. So I work in Varanasi, which is hub of UP, MP, and Bihar. We get 80% patients from these three states, which are also the most populous states of the country. And head neck cancer and gallbladder cancer, these two are the capitals. These two form a very large bulk of the patients. And we see a lot of patients with stage 4B disease, stage 4C disease. So that is the problem. I think when patient has so much huge disease burden, what patient will want is rapid symptom control. Sometimes extent of survival, which we know immunotherapy might add life to around 10 to 15% of patient for a very long term, but will not happen in 80 to 85% of the patient with the present immunotherapy which we are utilizing, single agent PD-1 inhibitor, which we are utilizing. Yes, the things are rapidly evolving. More effective combinations of immunotherapy. We are now having multiple microbiome projects. I think that will change the way immunotherapy reacts. The same immunotherapy which we are already utilizing, we can increase the responses from 20% to at least 40%, but that is still not coming to the main stream. And we are left with drugs of EGFR inhibitors, drugs like cetuximab, which are known to have a rapid tumor response, and especially in combination with chemotherapy. So PDL1 status, we had our internal audit, which is not yet published, but we'll be publishing when we have a PDL1 data of close to 10,000 patients. We already have data sets of 7,000 patients of advanced head and neck cancer. So that data of 10,000 patients with PDL1 shows that a lot of patients have PDL1 below 20%. PDL1 less than 1% is also occurs in around 10% of the patients. And PDL1 below 20% occurs in around 50 to 60% of the patients. So yes, PDL1 very high is not very common. It can occur in 20 to 30% of the patient, but the extremes are more rare. Performance status, again, we see the patients having presenting at PS2 or PS3 stage. Giving a metronomic treatment is one of the most commonly utilized regimen in terms of the cost, in terms of the utilization. We have done at least 3 randomized trials of metronomic therapy. One, metronomic therapy alone in second line setting. Second, metronomic therapy in combination with low dose immunotherapy. Third, metronomic therapy in combination with paclitaxel and carboplatin. 2 have been published. One is under publication. Fourth one is metronomic therapy in combination with low dose immunotherapy and in combination with probiotic. That is just started recruiting. So all these are ways by which we are able to manage some of our patients of advanced head and neck cancer. But the problem remains the same. How to get rapid responses and responses which are meaning for the patient. That is the type of patients which we are dealing with actually. A large disease burden. You can see entire buccal mucosa eaten by the abdominal disease, large bleeding tumors. I think giving immunotherapy in so large disease burden when the patient is not able to fit